Are we good to go, guys? Thank you. So today, this is a part of labor and delivery module, and the guideline that we'll be studying is a nice guideline called fetal monitoring in labor. Now, before we move on to what the actual CTG is, we'll have to read a bit about the background, which is given in the guideline. So, what the guideline says is that for every mother, it is essential that we talk about the monitoring of the fetal heart rate in labor during her antenatal visits. And whatever her choice is, that needs to be documented in her personalized antenatal notes. So, this decision as to what is used, either intermittent auscultation or continuous cardiotopography, this can be decided by taking into maternal considerations as well as fetal considerations. Okay. You have to offer her support throughout labor, and you have to tell her that this is something that is very dynamic, which can change if new risk factors come up, or if the risk factors that had come up have gone down or have settled down and can even be stepped down from CTG to auscultation. Okay. Now, whenever we do an assessment in labor, it has to be an hourly assessment. And on that, you have to report the frequency, length, and strength of her contractions. You have to take it note of antepartum, that is antenatal risk factors, for example, hypertension or diabetes, and intrapartum risk factors as well. For example, uh, leaking per vaginum, that is premature rupture of, pre-labor rupture of membranes for more than 24 hours. All of these factors are to be considered. You have to see the well-being of the mother. That means her vitals are to be checked as well as the fetal well-being is to be uh, taken into consideration, and how the labor is progressing. So the guideline time and again tells us that whatever we do, so the CTG is not something that is to be done just as a diagnostic tool alone. It is to be done in congregation with the mothers and the fetal condition. Correct? So you have to look at the whole clinical picture. So that is what it's saying. Fetal heart rate monitoring is a tool to provide guidance on fetal condition and not a standalone diagnostic tool. The findings from the monitoring need to be looked at together with the developing clinical picture for both the woman and the baby. So this is something which is very important for our practice, because we just can't look at a CTG without knowing the history of the patient. So even questions would be asked you in such a way in the exam wherein they will obviously give you some clinical stem and history of that particular woman. Okay. So now when a woman presents to you in the labor for the first time and you're doing an initial assessment, you have to see the risk factors, that is antenatal risk factors and intrapartum risk factors, as well as how the fetus is doing. Then decide whether she's up for intermittent auscultation, and that would be in low risk women, or would need cardiotopographic monitoring. Apart from our initial risk assessment, it is essential that we look at her antenatal care plan that has been given or noted down in her personalized notes. You have to explain, as I said earlier, that it is a continuous assessment, and any method might change at any time. It might be stepped up or escalated if she's on intermittent auscultation. I hope we're clear so far. After this, if there is no known risk factors, correct, if she's a completely low risk patient with a healthy baby, healthy mother, you can tell her one more thing, that additional CTGs, if done unnecessarily, could also increase the risk of unwanted interventions. And thus, it is very crucial that we take the whole clinical picture into account whenever making these decisions. Women who are low risk for complications, um, we would offer them intermittent auscultation when in established stage of when in established first stage of labor. How can we do that? You can use either a Pinard stethoscope or a Doppler ultrasound. You can carry out intermittent auscultation. Now, this is an important question. How do you carry out the intermittent auscultation? Here, immediately after a palpated contraction, listen to the heartbeat for at least 1 minute. Repeated at least every 15 minutes. Record it as a single rate on the partogram or in the woman's notes. We have to record the accelerations and decelerations if heard, and palpate the maternal pulse hourly or more often if there are any concerns. And it is very crucial that we differentiate between the uterine souffle and the fetal heart rate, because the uterine souffle would coincide with the maternal pulse. Okay. If during the first stage of labor you feel that you cannot localize fetal heart rate, you have to get an immediate real-time ultrasound done. When she is in the second stage of labor, okay, that is, she's fully dilated, what would you do? You would perform intermittent auscultation immediately after a contraction for at least 5 minutes, and this is to be repeated every 5 minutes. Okay, so after every contraction, you listen for 1 minute. In first stage, you listen for 15 minutes. In the second stage of labor, you listen every 5 minutes. Sorry, and again you record it as a single rate on the partogram. Palpate the woman's pulse. And if you have difficulty in differentiating between the heart rate of the mother or the baby, then you can seek help. Now, this is something that they have given importance to, that if, for example, there is a patient who came to you and she's in labor and she's always had a heart rate of, let's say, 130, fetal heart rate of baseline of 130 beats per minute. Okay. However, during labor, you find that if there's an increase in the fetal heart rate of more than 20 beats per minute, okay, from the baseline, shift up of the baseline, or if there's a deceleration means a dip of 15 beats per minute lasting for more than 15 seconds, then what would you do in such cases? These are women who are low risk women. Okay. Here you would do more frequent auscultations, or you would ask for help or seek a senior help. You look at her history, identify the risk factors, look at the clinical picture, look at how the labor is progressing. You can offer CTG, and if she's in a midwifery led unit, for this CTG, you would have to transfer her to an obstetric led unit. Then, after 20 minutes, if the CTG is normal and if there are no additional risk factors that have come, you can offer her to step down to return to intermittent auscultation. But however, if the woman denies, you can continue on the continuous CTG. Okay. Am I clear so far, guys? Are you understanding the whole concept for low risk women? We stick with intermittent auscultation. But if on intermittent auscultation we find that there is a baseline shift of more than 20, or if there's a deceleration, then we would do these steps. You would summon help, more frequent auscultations, look at the whole clinical picture, offer CTG and SOS transfer if needed. And after 20 minutes, if 20 minutes on the CTG, if it's normal and there are no additional risk factors, you can offer even stepping down to intermittent auscultation. Are we clear so far, guys? Are we clear? I hope all of you are understood till now. Now, next, we are going to go ahead and move to whom do we offer continuous CTG. Okay. The first would be that if this woman was on intermittent auscultation and then due to some concerns, we have shifted her to continuous CTG, and on those CTGs, we have abnormalities. What those abnormalities are, we'll obviously look at. But if these abnormalities come up, then we offer her the continuous CTG. Or if in her care plan, there were some antenatal risk factors or some other risk factors that would warrant a continuous monitoring of the baby during labor. Okay. Now let's look at the risk factors in the mother. Okay, so these are maternal risk factors antenatally that would warrant a continuous CTG. If there is a previous cesarean birth, that is a previous LSCS. So this is a given that vaginal birth after cesarean trial would require continuous CTG. And if there is any other full thickness uterine scar. So now guys, tell me, why would you offer someone who is been given a trial for VBAC continuous CTG? What do you want to try to determine on that, or pick up something that would be helpful? You all can type it in the chat box, guys, so that I know if you're thinking on the right path. Why would we offer continuous CTG? Correct. Rupture of scar or dehiscence of scar. And how would it present on the CTG?
Fetal distress.
Correct. There would be bradycardia. There is bradycardia, and that's the first sign of scar rupture or scar dehiscence on the CTG. So the fetus would present with bradycardia, but the mother would have tachycardia. Okay, correct, guys. Thank you. Any hypertensive disorder needing medication, be it chronic or gestational, prolonged rupture of membranes, but women who are already in established labor at 24 hours after their membranes ruptures do not need a CTG unless there are other concerns. Prolonged rupture is more than 24 hours. Any vaginal blood loss other than show, suspected chorioamnionitis or maternal sepsis, pre-existing diabetes, that is type 1 or type 2, and gestational diabetes requiring medication. These are the maternal risk factors for which we would offer continuous CTG. On the other hand, what are the baby risk factors or the fetal risk factors that you would offer continuous CTG for? Here, any baby who's in a non-cephalic presentation, for example, there's a breech presentation, and even when there's a discussion ongoing whether you want to go in for a breech trial or you want to go in for a cesarean, you can still offer the CTG till that decision is made. If there's fetal growth restriction, small for gestational age babies, advanced gestational age more than 42 weeks, that is, they are post term pregnancies, anhydramnios or polyhydramnios, and reduced fetal movement in the past 24 hours before the onset of regular contractions. These are the fetal indications for which you should offer continuous CTG. There are other set of population where you can offer continuous CTG is when they develop these new intrapartum risk factors. The first slide that we saw here was antenatal risk factors like diabetes, hypertension, or a previous LSCS. These were the baby risk factors. And this is intrapartum if the woman develops any of these. First is contractions that last longer than 2 minutes or frequent contractions, that is 5 or more contractions in 10 minutes. If there is meconium, maternal pyrexia of greater than 38 degrees Celsius on one occasion or more than 37.5 degree on two occasions taken 1 hour apart. Okay, so this is 38 is 1 and 37.5 is 1. Suspected chorioamnionitis or maternal sepsis. They've put this point if that woman feels a pain which is much more than what she was initially feeling, then also you can offer a continuous CTG. Fresh vaginal bleeding, blood stained liquor not associated with vaginal examination, that is likely to be of uterine origin. Pulse of the mother more than 120 beats per minute, taken on two occasions, 30 minutes apart. Single reading of BP 160, 110 or more, or two readings of 140, 90 millimeters of mercury, taken 30 minutes apart. 2 plus urine albumin or urine protein, and a single reading of BP equal to or more than 140, 90. And if there's a diagnosed first or second stage delay in the labor. If the woman has been given regional anesthesia like epidural, that would need continuous monitoring and the use of oxytocin as well. If we are augmenting labor, then we would want to give, we'd want to offer continuous CTG. Now, I'm going to ask you quick questions because I've taught you a labor. Would regional anesthesia be given in a midwife-led unit or in an obstetric unit? Anyone? Would regional anesthesia, that is epidural, be offered in an obstetric unit or a midwife-led unit? You can type it in the chat box. Even if you're wrong, it's fine. Obstetric unit, correct. And before augmentation of labor, that is before giving oxytocin, would I offer her epidural? Yes or no? Correct. So these questions you'll have to remember, and these small points you have to remember because in extended matching questions, these matter. Okay. Next slide, we'll move on to. So now, in general, there's a consensus that the fetal heart rate is healthy. That is when it is between 110 beats per minute or 160 beats per minute. With normal variability, we have to continue usual care as the risk of fetal acidosis, hypoxia is all low. Differentiate between the fetal heartbeat and the maternal heartbeat hourly or more often if there's some concern. I don't want to go too much into the detail of this. Now, next thing that I want to talk to you all about is the CTG per se. Okay, I want all of your attention here because this is what we're going to read. Okay. I'll just take another 15-20 minutes, then we'll be done. And I know you all will be able to ace CTGs after this. Okay. Now, here for CTG interpretation, we have a short form that is Dr. C. Bravado. DR means determine risk. C means contractions. B
कल
is,
कल पापा लेकर आ गया मैं।
please mute yourself, guys.
डैडी ने वो दे दी वहां दादू में टिनड़ी को।
Guys, please mute yourselves.
पता नहीं कैसे मुड़का पता
Uh, Back end team, please mute everyone other than me, guys. Please. Thank you. So now we will be talking about CTG. That is, the short form here is Dr. C. Bavado. DR means determine risk. C is contractions. B is baseline. V is variability. A is accelerations. D is decelerations, and then overall assessment of the CTG. Okay. Now, before this, for risk determination, we have to consider prenatal risk factors, as I told you, antenatal risk factors for the mother, intrapartum risk factors, fetal risk factors, the progress of labor, and if there are any other concerning factors like fetal growth restriction, uteroplacental insufficiencies, all of this has to be taken into consideration while we are trying to interpret the CTG. Okay, so as mentioned earlier, we have to look at the whole clinical picture. Then the C stands for contractions. Okay. Now, how do you measure these contractions? We have internal monitoring as well, in which is basically with a transducer, uterine transducer, but nobody does that nowadays because our CTG machine usually has a it has a toco probe, which is basically the transducer, which will help in the tocodynamimeter, which will help in understanding the uterine contractions. To categorize the contractions, we have now another thing. Before I begin, I want to tell you all this, that there is no concept of reactive, non-reactive, suspicious anymore, or category 1, category 2, category 3. The NICE guideline categorizes it as white, amber, or red. Okay, that's the latest development in this. So white features are basically the ones which are supposed to be good, amber is in the middle, and then red is something that is alarming. Okay, so white means if everything is normal, that means it's less than or equal to 5 contractions in 10 minutes. Tachysystole is when contractions of more than 5 minutes happen in 5 contractions in 10 minutes. Hypertonia is contractions lasting for more than 60 seconds. And hyperstimulation comes in when there is tachysystole, that is more than 5 contractions in 10 minutes, and the fetal heart rate is also affected. Okay, so let's revise it. The first thing is white, that means everything is okay. There are 5 or less than 5 contractions in 10 minutes. Then comes tachysystole, that means more than 5 contractions in 10 minutes. Then there is hyperstimulation, more than 5 contractions with abnormal fetal heartbeat. And then there is hypertonia. Tone means the tone of the uterus, it's lasting longer. So that means the contraction is lasting for more than 60 seconds, that is more than 1 minute. Okay. And what do you do when this happens? The corrective measure is that, first of all, if she is on oxytocin, okay, so we would stop the oxytocin immediately. And we can give a short acting tocolytic, for example, terbutaline 0.25 mg subcutaneous. This is what you do, and this is called as the corrective measure to decrease these excessive contractions. Okay, so here there's just white and amber. Okay, next we'll talk about the baseline heart rate. Okay, now to determine the baseline heart rate, you have to look at the mean fetal heart rate, excluding the acceleration, that is the upward flick and the downward flick over a period of 10 minutes. It's an average heart rate. Okay, now let's look at this picture first. I'm going to zoom it for you guys. What is the average heart rate looking at this, guys? So this is 120 and this is 150. So these are three boxes. So this is approximately, if you remove these accelerations, if you remove them out, this is the baseline. And you have to see this over the period of 10 minutes. Okay, so this approximately would be somewhere between 130. Do you all agree, guys? Give me a thumbs up if you all agree that this, on an average, this would be 130. Yes, correct. So what we have to do is we have to exclude the upward flicks and the downward flicks. Okay. So no accelerations, no decelerations. Correct. Now, I'm sorry. Yeah. Now, next, let's look at what is supposed to be white and what is supposed to be amber. As I said, the normal heart rate, the normal heart rate is between 110 to 160 beats per minute. Amber here would be increase in baseline from what it was by 20 beats per minute. If it is between 100 to 109, and unable to determine baseline. Sometimes it's so difficult to determine a baseline that you will not be able to tell because it's just up and down, up and down, up and down. Okay. Red is below 100 and above 160 is also red. Okay. Lower baseline heart rates are expected in post-term pregnancies, whereas in preterm pregnancies, they tend to be above 160 most of the times. A rise in baseline fetal heart rate may either represent developing infection or hypoxia. So you have to give extra attention to these shifts in baseline. Okay. I hope this is clear, guys. Let's revise. What is white? White is 110 to 160. What is amber? Amber is shift of baseline about 20. Then less than between 100 to 110. And if you cannot determine the baseline, that's an amber feature. And red is less than 100 and more than 160. Okay. As I said, we could find the heart rate here was 130. Now here, if you can see that the baseline is almost 180. Correct. So this is outright tachycardia, fetal tachycardia. And here the baseline is somewhere 100, below 110 and it's between 110 and 100. So this is bradycardia. Okay. I hope you all are be able to understand this now. Okay. So whenever we read, we first look at the contractions. Now here, obviously the contractions are not given. Here the contractions were given. Okay. So they are fine. Okay. It's not 90. 90 is here. It's just above 90. So it's around 100. So we looked at the contractions, then we looked at the fetal baseline. Now for the baseline also, there's an additional characteristic called as variability. Okay. So variability is the oscillation in the heartbeat. Okay. Which is irregular in amplitude and frequency. So let's look at this one. So this has good variability, guys. This picture, you can see that there is variability present. Okay. See, this is a variability. Can you see these small, small ones? These are the variabilities. Correct? Now, if the variability is absent, sometimes when you do a CTG, there are babies who will have a flat NST. Okay, it's like a flat line ECG. Basically, there is no variability, and that's a really, really concerning feature. We should expedite delivery in such cases. Another thing that we notice is sometimes meconium or post-dated pregnancies can also have decreased variability. Okay. So in such a case, you have to take in the clinical picture, look at the risk factors, look at the other uh, things like the labor progress as well. Now, for variability, when it is between 5 to 25 beats per minute, that's ideal. Okay. That's supposed to be white characteristics. If it's amber, that if it's less than 5 beats per minute for 30 to 50 minutes or more than 25 beats per minute for up to 10 minutes. Red is if it's less than 5 minutes for 50 minutes, more than 25 beats per minute for 10 minutes, or if it's sinusoidal. I'll show you all of these pictures in the end, don't worry. Now, in this picture, can you see the variability? Can you even understand how much the variability is? The woman is having contractions down there, fine. Okay, if it's a 20-minute CTG, we divide it into half. She's having adequate, they are less than 5 contractions, so it's fine. Can you see the variability? It's very less, hardly 5. Not even 5, it's less than 5. So this is basically decreased variability. Okay. Variability will usually be between 5 to 25. That's ideal. But sometimes when the baby is sleeping or in a period of quiescence, they can have reduced variability. Certain medicines like opioids can also cause reduction in variabilities. Other risk factors should also be taken into consideration. For example, if there's a rise in baseline, that could be suggestive of sepsis or infection. Increased variability refers to oscillations around the fetal baseline that are more than 25 beats per minute. And these are also bad because that can be that can be associated with worsening fetal condition. So anything even less than 5 and more than 25, both is worrying. Only the additional thing here that they have put in are these minutes. Okay. So how do you remember this? Amber is something which is in between and red is bad. We've understood this by now, correct? So it's 5 and it goes with 30 to 50. And 25 always goes with 10, correct? So you have to see if it's more than 10 minutes, it's a red feature. It's less than 10 minutes, it's a amber feature. If the variability is decreased for 30 to 50 minutes, it's amber. For more than 50 minutes, it's red. Okay. Please use these slides for your revision because I've given it to you all in a very picturesque way so that you all can remember it easily. When you'll go to read the guideline, it's just given in a point-wise manner, so that will be difficult to recollect. Now let's come to decelerations. Okay. Decelerations are basically dips. Decrease in the fetal heart rate below the baseline for 15 beats per minute, with each episode lasting 15 seconds or more. When looking at the decelerations, you have to take into the consideration factors like their timing, whether they're early, variable, or late, the duration of the decelerations, whether or not this deceleration comes back to the baseline, how long they have been present, whether they occur over 50% of contractions, and that is defined as repetitive. When the concept of repetitive comes, that means they are present over 50% of the contractions. Like if they are, for example, we are saying that they are early decelerations. Early decelerations occur with the contractions. And if they are, or if they are variable, variable will occur anywhere. They are not related to contractions, but they are, if the contractions are, let's say, we have 5 contractions and the variable decelerations are 4. That means that more than 50% of contractions, these variable decelerations are present. That means they are repetitive variable decelerations. Okay. The presence or absence of shouldering. Shouldering is that when there is so whenever there's a deceleration, before that there's just slight flick upwards and then it goes down. That happens because of compression. Maybe for example in umbilical cord compression, when the umbilical vein gets compressed, the slight upward tachycardia and then it goes down. That's deceleration. Okay. That's basically called as shouldering. It's basically, I'll just show you. I'll draw it out for you. It's like if this is a deceleration, it'll go up like this and then come down. That is shouldering. Okay. And if there is variability within the deceleration, there are some concerning factors like lasting for more than 60 seconds, reduced variability within the deceleration, failure or very slow return to baseline, and loss of previously present shouldering. All of these are concerning features. So this is also important to remember. Now let's look at the types of decelerations. We have early decelerations. They begin with the contraction, dip when the contraction is the highest, and then return back. So this is the shouldering. You can see there's a little up here and then it comes down. Or here, even in the variable ones, you can see that it goes up a little, it comes down, then goes up again. So that's variable deceleration. Here, early decelerations usually happen because of head compression. So they're not always pathological because that can be seen in labor as well. Then late decelerations happen due to uteroplacental insufficiency. The deceleration starts after the contraction has peaked. And variable are due to umbilical cord compression and they are irrespective of the contractions. Are we clear with this, guys? Are we clear so far? Just give me a thumbs up if you'll have understood the difference between early, late, and variable. Early happens when the contraction starts, the deceleration also starts. Late will happen after peaking of the contraction. And variable will be irrespective of the contraction. Even if she's relaxed, there is still a deceleration. That's basically variable. So there's a method how I remember it. Variable looks like U, so it's umbilical cord compression. Late is L. L stands for placenta, L. So that's late deceleration is placental insufficiency. And then only head remains. So HEE is early deceleration. Okay, so that's how I remember these three things. This is just another example of classification: early, late, and variable. Now, here there are features that are important, and I want you all to pay attention. White is when there are no decelerations or when there are early decelerations. As I told you, presence of early decelerations is not always scary. Variable decelerations that do not have any of the concerning features. What were the concerning features? That they were more than 60 seconds, absence of shouldering, reduced variability, and delay to or no return to baseline. These are our four concerning features. If any of these are not present, then we call it white. Amber is repetitive. If you remember repetitive variable decelerations with any concerning characteristics for 30 minutes, non-repetitive variable decelerations with any concerning characteristics for more than 30 minutes, and repetitive late decelerations for less than 30 minutes. Late decelerations are always bad because that they have a worse prognosis because that's associated with uteroplacental insufficiencies. Red is repetitive variable decelerations for more than 30 minutes, repetitive late decelerations for more than 30 minutes, and if there's acute bradycardia or a single prolonged deceleration lasting for 3 minutes or more. Okay. Here we have to do an urgent review and start to carry out corrective measures like changing the position, doing a pervaginal examination, ruling out a cord prolapse. If she's having too many contractions, decreasing those contractions, giving her hydration, giving her oxygen supplementation, all of this. Okay. Now here, let's look at this one first. What do you think this is? The first one. This is our contraction, and our deceleration is starting with it and ending, and the pickup is there immediately after the contraction. So this is a classic early deceleration. Okay, its peak is this decel. This coincides. Are you able to understand, guys, that it's coinciding? Yes, it's early deceleration. Now let's look at this. Our contractions are these, whereas this is starting after the contraction. So that's kind of a late deceleration. Okay. And also she has a lot of contractions. That is to be remembered here. Now this is, what is this, guys? These are our contractions, correct? But are the decelerations associated with the contractions or not?
Not
Guys,
associated with control.
yes, this is not associated with contractions. So these are variable deceleration. Okay. What is this? Anyone? It's a very classic pattern of fetal heart rate. Variability, actually.
Variable,
Yeah. What
variable
variable?
data.
No, this is sinusoidal. Okay. These are basically cycles of 3 to 5, they just go up and down, and there is no baseline. This is classic sinusoidal pattern. Yes. It's seen in fetal anemia, be it parvovirus B19 infection, which was a question in the past exam, or RH isoimmunization, or, hypoxia distress also can present as this sometimes. Okay. This is sinusoidal. Okay. The one down below. And this is the normal one. All of these are sinusoidal ones. If you can understand the stark difference between the two. This is non-sinusoidal. See, normal heart rate. This is sinusoidal. It's like sawtooth kind of a thing. Then let's talk about accelerations. Accelerations is transient increase in fetal heart rate for 15 beats per minute for lasting for 15 seconds. The presence of fetal heart rate accelerations, even with reduced variability, is generally a sign that the baby is healthy. However, the absence of accelerations or the otherwise normal CTG doesn't mean that the baby has, fetal acidosis. So that means that if the CTG otherwise is good and there is no acceleration, the baby could have a sleeping time or a quiescence period. So we would want to maybe repeat it after some time, but that doesn't mean that it's a suspicious. That means it's not an amber feature, correct? Otherwise, normal CTG, absence of accelerations, it's fine. Okay. These are classic accelerations, as you can see here. And in the end, we have to categorize the CTG. Okay. And how do we categorize the CTG? We categorize this CTG if it's normal, suspicious, or pathological. Okay. The features that we see are white, are white, amber, or red, and the overall assessment is not reactive or not is not normal or not reactive anymore. It's normal, suspicious, and pathological. Normal means no amber or red feature. That is, all four features are white. What are our four features? That is baseline, variability, acceleration, deceleration. Okay, and contractions as well. Then suspicious if one feature, any feature is amber, and pathological if one feature is red or two features are amber, two or more features are amber. Here we have to assess fetal well-being every hour, and you have to take into consideration the whole picture. Discuss the changes and implications. If any of these features come up, if she needs continuous CTG, if she needs further intervention, you can do this. Another thing is that for second stage of labor, interpreting CTGs becomes a little more challenging. So here you have to understand that every 5 minutes intermittent auscultation is done. If the fetal heart rate accelerations are recorded, be aware that sometimes they could be maternal pulse. If there are decelerations, look for other signs of hypoxia. For example, a rise in baseline heart rate or a reduction in variability. These are signs of hypoxia, okay, along with the deceleration. Take into account that onset of hypoxia is both more common and more rapid in the active second stage of labor. Take an increase in the baseline of 20 beats per minute or more from the start of labor or since the last review as a red feature in active second stage of labor. Okay. What are the corrective measures that we can do? As I said, we can do maternal positioning, change, encourage the woman to mobilize or alternate position or avoid supine position as that can cause hypoxia to the baby. Avoid hypotension, so we can give intravenous fluids, left lateral position, and you can get an anesthetic review. Maternal hypoxia or a part of anesthetic pre-oxygenation can be giving oxygen to the mother. And if the CTG trace is suspicious with antenatal or intrapartum risk factors, we can do digital fetal scalp stimulation. Okay. If this leads to an acceleration in fetal heart rate and a sustained improvement in CTG, you can continue to monitor the fetal heart rate. However, absence of an acceleration in response to fetal scalp stimulation is a worrying sign, and that might show that the baby is not doing well, that the fetus is compromised, and we might need to do a expedition of the delivery. Another line that they've said is that fetal blood sampling is something that they've not commented upon in this guideline. They've just commented about fetal scalp stimulation. And this guideline is only to be used for understanding intrapartum CTGs. Correct? That is in labor CTGs. This was basically the end of my presentation today. I'm just going to go over the pictures with you all again so that you all get a revision. This is accelerations. This is sinusoidal pattern here. This is normal pattern. This is a little bit of sinusoidal. This is sinusoidal again. This is sinusoidal. These are variable decelerations because they don't match. These are early because the peak of a contraction coincides with the lowest dip and then it does recovery. This is late because it starts after peaking. Okay, peak of contraction is happening here and then it's starting. This is late deceleration that happens in uteroplacental insufficiency. This picture is important. I want to make a note. I want you all to remember this. This is how you all will be able to understand early, late, and variable. Okay. So, I'm at the end of my session today, guys. I hope you all understood this. Fetal scalp stimulation is by just doing a pervaginal examination and trying to stimulate the fetal scalp with your finger. Okay. I hope you all were able to understand this concept of CTG. It's not difficult. You all will be able to look at pictures. You all can go online and even ask the team to share a site with you all which had good pictures of the different types of CTGs. And by the end of our by our course and while we are doing these questions, I'll also ask the team to come up with a document which has all the CTGs possible so that you all can look at them as pictures. Okay, because it's important to be able to decipher these CTGs. And another thing is that you have to try to remember the small nuances in the variability, the minutes, all of these are what is an amber feature, what is a red feature, and then how do we categorize it as normal, suspicious, and pathological. Okay. So it was nice meeting all of you today, and those who joined in who've not in our course and have joined it as a free session. I hope you all were able to learn something new and increase your knowledge. For those who are our regular students, I'm hoping that you all understood this part. I think this was the main thing that was left in our labor and delivery module. and that this will help you to solve questions better.